Hi everyone, this is a patient who is 33 years old. This is his left knee. He works out and he's a runner and he's got a tear in the medial meniscus. This is medial meniscus. This is the medial femoral condyle, tibial plateau. This is the left knee. And this is abnormal to have this type of tear. It shouldn't be an unstable fragment like this. This will make patients feel that the knee feels unstable. It feels like it buckles, catches, locks, gives way. And there's actually a little bit of mild arthritis. See how down here this kind of looks like a crater in the moon. So that's unfortunately a little arthritis already that he suffered. So get in a shaver here in order to look inside, take care of that meniscus tear, trim it out, maybe make it lighter. And try to see if we can access it this way. And get back to the shaver. This is more of a central horn tear, so one that might be a little bit tougher to get at. So you want to try to remove as little as you can, and just what's unstable, and keep the remaining meniscus and smooth it into a stable. Get that shaver back. Let's take out what I can. This patient's wife was working as a nurse in a hospital in Brooklyn, so because of COVID, I decided to tell him, let's wait, because we want to make sure he doesn't get sick. And then if he gets sick, we don't want him coming into the surgery center. We haven't had any COVID cases yet, which is great, and we want to keep it that way. And time went by, his wife never got sick, no fever. He has no fever when we checked him this morning, so I'm really glad we did it that way, and I think we did the right thing. He ought to do really, really well. He's young and fit. Likelihood that a person with COVID who's only 33 is going to have trouble is very, very low. It's not zero, but it's very low, so that's good. It gives me confidence. So this is me. I had moved the scope into the other portal so I could look a little differently. Now you see the remaining meniscus has been smooth into a stable rim. So now we move back into the knee in the opposite portal, and then go into the rest of the center part of the knee. I'm going to shape this. So it looks like he's got some damage to his ACL. I believe he had ACL work done in the past, right?
Yeah, I believe he's probably about 12 years out, I think, from an ACL reconstruction. Meniscectomy.
So this is the ACL. And water here. So this is an ACL. This looks like it's not perfect, but not bad. The problem with ACL reconstructions is there's about a 15 to 30% chance that after the ACL reconstruction, the patient will have, some kind of issues with their sports and their activities that they may need a second surgery, not on the ACL necessarily, but on the meniscus. So now we're looking at the opposite side called the lateral compartment. That's the outside of the knee. And we see some changes here, some mild arthritis. Tim, I wonder whether or not that ACL is incompetent, and that's part of his issue.
We should examine one as a nerve disease.
Yeah. And there's a tear of the posterior horn of the lateral meniscus, but the root seems to be intact. We'll take a better look. He's also got some significant changes already. See? Probe. Okay, so here's the tear.
Is there another squeezage up here as well?
Yeah. Yeah, he's got a lot of damage over there. So the question is, what do we do with that split? What do you want to do? You want to take all this out? He's only 33.
Yeah, I mean, he's already lost a fair amount of meniscus immediately.
Yeah.
Depending on how stable it is.
Yeah.
We have that cleavage anteriorly that I don't think needs to be much about it except clean that up. We weren't anticipating a reparable repair.
Nor do I still think that is repairable unless we do a revision ACL. And it's possible that he had that 12 years ago, and then he just kind of left that tear as is. So, a lot of doing good work is decision making intraoperatively. The MRI scans are accurate, but they're not 100% accurate. Sometimes we resort to looking inside the knee of the patient with them awake in our office. Sometimes in the operating room, we use certain technology. This is a little unstable, but I don't think it's that unstable because of the popliteus, because of the hiatus. So, can we lower the table, please? Sure. I think we better do this and then reassess him in the OR to see his pivot from the end. Thanks, no problem. Okay, so, you know, this is a little cleanup. This is one of those 15 to 30%. The question is, now, after all the damage we're seeing, do we need to eventually talk to him about revising and doing another ACL reconstruction on him? I'm not sure who did it 12 years ago, but it looks like they did a decent job, but sometimes they just don't take it. It's a little loose to me.
Yeah.
Can you straighten out the phone? Yeah, I think that's probably the issue. It doesn't look like, oh, he had an autographed hamstring. Looks like maybe a hamstring, yeah. So yeah, this is what's great about arthroscopy, is it can both be diagnostic and therapeutic. So this is the undersurface of the kneecap, a little synovitis here that we'll take out. Not bad, not the main issue, but just clean it up. And then take a quick look at the letters. So, less tell us the central part. I mean, I can understand why he's suffering so much. Poor guy. You need to talk to him.